Okay, can you hear us now? You can hear us. Lovely. So I was just saying the title that I was given was to look at consider whether antimicrobial resistance and climate change are a marriage of convenience or a love match, and maybe think about the work that we are doing at the interface of antimicrobial resistance and climate change in response to funders and calls around understanding how climate change impacts health, or whether we are being opportunistic and looking for questions where they really don't exist, or where there is already a logical explanation. Or really, is there a thing that we need to consider when we do research on infectious diseases? So as I mentioned, we have a grant, a very small grant, looking at the community level, at the lived experience of people in vulnerable communities in relation to antimicrobial resistance, and how extreme climate events may impact that. At the time when we wrote our grant, we actually talked about climate change, and I don't know how many people have studied climate change research as part of your work on infectious diseases. Climate change actually refers to changes happening, patterns of extreme climate events over long periods of time. So we're talking decades, 20, 30, 40 years. Whereas what we experience on a day-to-day basis is the weather. And sometimes we may experience extreme climate events like flooding, like heat waves, like droughts. So to claim to be studying climate change in relation to AMR, actually, logically, you would need to spend a lot more time to look at patterns of epidemiological data from infectious diseases alongside patterns of changes in behavior in weather patterns. And I don't think we are doing that at all. So it's something to bear in mind. I think the terminology around the science of climate change is being used and abused in different ways, in the same way as AMR terminology is. So it's something that we need to consider. So bringing it back to infectious diseases and how and why this matters, we have conducted in collaboration with colleagues, and when I say we, the majority of the work was done by Joseph Nunit, who's an incredibly talented modeler at Berkeley, looking at the existing evidence for infectious diseases in low and middle-income countries and which interventions would have the most impact in terms of mitigating the threat of AMR and averting deaths. And from all the existing evidence from scientific research that we have up to date in terms of interventions, he modeled, I'm sorry this image is projecting very clearly, but what his modeling showed is that the biggest bang for buck would be in providing access to water, hygiene, and sanitation, and vaccination programs and infection prevention. Logically thinking, those are also the interventions that are going to be most impacted if there are extreme weather events such as flooding or heat waves. It's access to water that is compromised, access to vaccination programs, through access to roads, to networks, hospitals. So logically, it makes sense. There is a relationship, and it's something that we need to look at and consider. But where is the evidence, and where is it taking us? So there is a lot of work that is being done that specifically looks at elevated temperatures, increased greenhouse gases, extreme weather events, and how they impact not only infectious diseases, but non-communicable diseases too. And we can't look at disease conditions in people in isolation. It is all part of the continuum of our health experience, living in the environments in which we live. So any changes we observe that we attribute to extreme weather events are or need to be taken into consideration with what is happening to the environment in terms of malnutrition, in terms of the vector-borne diseases that are impacting different parts of the world and different parts of the countries, not universally going to be affecting any individual country necessarily. So it's a very complex picture within which we are trying to find causalities out of obvious studies to date. So to do this work, I went back a little bit to look at the evidence. Now, this is a very crude analysis. I wanted to look at where the density of publications, scientific research is in these fields, and I looked at climate change and resistance. And I don't have to explain which is which. Obviously, commercial antibiotics have been used in the 1940s. So a lot of the evidence around antimicrobial resistance literature is since the 1940s, and there is almost 3 times as much scientific literature around antimicrobial resistance as there is around climate change. But if you look at the commercial, if you look at mainstream social media, a lot more noise is made around climate change than it is around infectious diseases and antimicrobial resistance. A lot of the early studies in climate change were actually about TB, and it was about changing the climate of person with TB and living conditions to see if that had these outcomes. The earliest paper that linked climate change to health was in 1990, 2001 by Fiona Godley, who was at the time an assistant editor at BNJ. Since then, she's the actual editor for a very long time, and she attributed health and environment, the changes in the environment to human health, specifically through looking at rising sea levels and how countries, including Bangladesh, for example, at the time, using controversial modeling, as she called it, would be submerged underwater, and that would have impact for emergence of cholera, of displacement of people, migration, and the knock-on effects. I found this quite interesting. This is one of the earliest papers that looks at TB and climate change, like changing the climate of a person, and the dilemmas that the American doctors faced at the time was questions being asked by their patients, such as, must I visit Havana to get better from TB? And so it was very different consideration in terms of what climate and health, relation to climate and health. And then when you look at infectious diseases and climate change, one of the first papers that brings them together, and this is a scientific paper, but that also uses the term, if I had to guess, because there was no evidence at the time, this is from the 1980s, 1991, and he projects that yellow fever, dengue, and malaria would be suspected in terms of relationships with climate change and infectious diseases. And then fast forward to today, of course, climate change takes up a lot of space in the social and mainstream media, like I mentioned. And there is a lot of sensationalization of the impacts of climate change. There is some association that is made with infectious diseases. There is research that is coming out that links rising temperatures with poor maternal and pediatric health outcomes and stillborn, for example, in developing countries. But what is the actual science in terms of what is that climate and the relationship with infectious diseases? So one of the things that I have looked at a lot in terms of this work and the work we're doing, and it's actually a very well-produced, consistent report about what is really happening to the climate globally and what we can learn from it, is the German Fortune report. It looks at climate risk index for countries. And what they actually do is look at the patterns of climate change by country and by different climate events over a period of time, over 30 years, as well as in any given year. And what they have estimated based on existing data for countries is that in the last 30 years, 832 million people have died as a direct consequence of climate change. Over 9,700 extreme weather events that have happened around the world. In the 2022 report that had been published, 7 of the countries that were most at risk of climate events were high countries. But over the last 3 reports, that has changed to now be low-income countries that are most affected by climate change or extreme climate events. Europe is the fastest heating continent. And so what they do is they look at by country at the climate risk index, but also correct for human development index, because they acknowledge that there is very little data from the countries that actually looks at patterns of weather outcomes and links it to human health and human outcomes. But when they correct for the human development index, nearly all of the countries in the top 20 are developing countries that are going to be impacted by change of climate events over time. And then they also look within a year, and again, the top 10 countries remain the same. They don't change. The majority of countries in any given year are 37% of climate mortality is linked to heat, so heat outcomes, and the lack of data in low-income countries makes it very difficult to make accurate predictions in relation to health outcomes, and I'll talk a little bit about that. But in terms of what are the main events that are happening, is mainly heat waves, storms, drought, and flooding. That is also, and all countries are impacted. It's not like any country has a low risk, has no risk of climate risk index. South Africa ranking has changed in the last few reports, but the data from low-income countries is changing based on the data. But what does it mean in terms of health outcomes? So there was a paper, a review that was done in 2024 that looked at actual health-related outcomes that have been projected based on climate-sensitive models. And specifically for low-income countries, they found 63 studies that specifically include countries. But what they reported is that there is a consistency in the types of diseases that are included. It's very, very select diseases that are considered in relation to outcomes for health. And it's only a few countries in the regions that are included. And out of the communicable diseases that are considered, Africa, there's only one paper in that report, in that review that was included from Africa. And they specifically looked at mainly vector-borne diseases, some enteric infections and respiratory infections. And overall, they predict there's going to be worse outcomes, there's going to be more deaths, there's going to be more hospitalizations, and more pressure on the healthcare system to be able to deal with this. What is really important to bear in mind is that in the German Watch report, they consistently do affirm the fact that no country is ready to deal with extreme weather events as we are experiencing them. For example, there was a heat wave in London last week, and a lot of the transport system came to a stop, and it made the news. So it's not that it's only countries that are poorly prepared, but the concentration of burden of disease and the living conditions are far more compromised in northern countries. So greater numbers of people are going to be affected by both communicable and non-communicable diseases. Since this, in 2024 or 23, there's been a specific review in the Lancet that was published looking at existing heat-sensitive models for infectious diseases and how they're predicting disease outcomes. They identified 37 models. Of these, the majority were for vector diseases. Majority is actually malaria. And they identified there's a shortage of predictive tools for respiratory, foodborne, waterborne, and soil-borne diseases. North American countries overrepresent the originator of the modeling studies and where modeling is being done. And one of the gaps is that a lot of the people who are developing these modeling programs and studies are not transparent about the code and not sharing so that other researchers in other countries can also use them. Since this was done, there has been a paper in Nature by a group of researchers looking specifically for using geotemporal modeling, climate modeling for malaria to predict what malaria will look like in the next until 2050 across the African continent. And what they predict and what they claim is that this is the first time that a modeling program has brought together vector, parasite, and environmental considerations in the same model. They don't say whether they consider the impact of vaccination or the impact of diet. All they talk about is treatment interruptions. But what they predict is that there will be 123 million extra cases, and 500,000 deaths attributed to extreme climate events in the continent, and that there will majority of these, so 79% of cases and 93% of deaths will be linked to extreme weather events. And these are the countries that are represented in the authorship of this particular model here. Then the next one, another study where is that specifically looking at antimicrobial resistance, again makes very tall claims that this is the first robust global evidence that rising temperatures are linked to rising antimicrobial resistance. They use IQVIA data and they use only conceptual-only data. And also there is an ecological fallacy in the study in that they look at country-level changes in climate, and that is also problematic because particularly with vector-borne diseases, they will be regional within the country, so there are issues with the way they do the data. They also found a more complex relationship between precipitation and AMR, which I haven't shown here. There's another graph C, which I didn't do, but that's more complex because they indicate that precipitation is a poor proxy for flooding and human behaviors that occur as a result of flooding. So they couldn't really make that. This is a slide from Professor Mendelssohn, which I've used before. I can't claim that I know have every paper in this slide, but there are also there are papers that try to explain how causality may be happening between AMR and climate change, predominantly around evolution, that bacteria will evolve under evolutionary stress to be able to withstand the pressures through climate, through heat, and particularly looking at, for example, cholera, salmonella, campylobacter, that these infections may become more of a problem going forward. There is a report this year that was published by Erta and Ramadan, our colleagues in One Health Trust, that looked at all of the evidence to date, looking at the relationship between antimicrobial resistance and climate change. And again, what they point to is that, yes, rising temperatures may be happening at the same time as changes in antimicrobial resistance patterns that we see, but there may be many considerations that need to be taken into account. It's not just a linear climate change and antimicrobial resistance. There are many things that are happening, including changes in farming practices, food production, movement of people, that influences the epidemiology of infectious diseases, but also human behavior that is impacted in climate. Another paper which I had a lot of difficulty, I tried really hard to understand this paper and make sense of it, and if anybody else has read it, please help me. But this made a lot of news this year, and it was a group of researchers who specifically looked at soil concentrations, antibiotic-resistant bacteria under drought conditions. They used existing studies, data from existing studies, and they only used hospital data to look at the epidemiology of the bugs. They only looked at specific countries, so USA, China, and Switzerland, and different environments, grassland, forest, wetlands, to see how drying of the soil concentrates, because there are natural antibiotics in the soil, and a lot of drug discovery focuses on that. But what they identified is that the drying intensifies selection and concentration of antibiotics, but selects for resistant antibiotic-resistant bacteria in the soil. And then they try to find a causation with emergence of clinical transmission by making the claim that dusty weather can spread the soil and then it can cause more exposure to this bacteria in human beings. Personally, I'm not the most eminent scientist in the room, but I think that needs more research to look at the causality and actually find a link. There are other explanations for this. For example, in drought areas, there may be longer distances to go to hospital, people may be more socioeconomically vulnerable. There are many reasons why things could be happening than just this. And they also themselves acknowledge that further research needs to be done in this relationship. So that takes me back to my research. No, carry on. No, interrupt, please.
No, take it out.
Anyone? So this takes me to my comfort zone and the kind of research that we do. This is a book that I read a couple of years ago, which I find really good to read if you study epidemiology infectious diseases by Hans Rosling. And it tries to look at epidemiological data and explain it in the context in which people are living and experiencing life. And it divides the world into 4 categories based on basic living needs that we have to have every day. You know, the kind of bed you sleep in, the kind of food that you eat every day, the transport you use to every kind of daily basis, and that categorizes you into different categories. And I would argue everyone in this room probably is a level 4, which according to him is $100 a day. And we may not all spend $100 a day, but we are living a life that is equivalent. This sentence he uses throughout the book is that the world cannot be understood without numbers, but it cannot be understood with numbers alone. So in terms of infectious diseases and antimicrobial resistance, we could argue the same, because currently a lot of the research space is focused on finding diagnostics, new diagnostics and new antibiotics. And of course we need them corresponding to antimicrobial resistance, but arguably we cannot respond to antimicrobial resistant infectious diseases only with new diagnostics and antibiotics. We have to look at the living environment and the many other factors that influence health outcomes. So just an example of what that looks like. This is with our team, we went to India towards the end of last year, because we had study sites there as well, and experienced how healthcare is delivered to patients. The 2 bottom pictures is the government hospital laboratory in the town of Bandi, which is a pharmaceutical town. It's built around the pharmaceutical industry, and this is the government hospital's enteric laboratory, where there isn't a hand basin, so staff cannot wash their hands, and the rats eat through the angle. And this is their TB lab. And the top one is state-of-the-art laboratories in a newly built hospital outside of Hyderabad. So arguably, most of the people in India are more likely to experience healthcare through an institution that looks like this than like that. So even within country, there's enormous variation in our access to healthcare and our exposure to pathogens based on the living conditions that we have. And then we also went to see the actual city around which that hospital in that is delivering care. There are a lot of people who live in slums. They come into contact with contaminated water, untreated water from the pharmaceutical industry, the effluent. And they also have access to a lot of informal vendors when it comes to antibiotics and medicines. So when we do our work and we focus in the hospital setting, it's a very idealistic way of looking at where people get access to healthcare, how they access antibiotics. So we went into the community, the slums, and we, with our team, we sort of were the secret shopper and we pretended to be ill, or that someone we had back in our room that was ill, and these informal drug sellers. This was pretending to be that we had there was a child at home who was ill, and he put together metronidazole, an anti-sickness, and I think this was a steroid. He put together a concoction, powdered it, and gave it to us in these pouches to take home. And then this other vendor, this other informal vendor, was actually injecting people. And two of the injectables were gentamicin and what is this one? Oxytetracycline. So, and these injectables were not obviously there was no cleaning process, there was no fridge, they were being reused to inject people. So, access to healthcare is important, and we can't assume everybody comes to a hospital, to get healthcare. So, the work we are trying to do now, and Tulani is driving this, and hopefully we'll do this as part of his PhD, is to understand and bring in these different indicators of health and well-being and vulnerability into our global health research. Because currently, the way we classify countries as non-middle income countries is very, by the World Bank categorization, is very crude, and we don't take into consideration all these factors which will influence our access to resources and to healthcare settings and health outcomes. And he presented it at, he's done some follow-on work to look at how current country classifications are masking disparities within country, but also within a One Health perspective, how we need to consider the sociocultural drivers, but also the environmental drivers of health, if we are really to understand the relationship between environment, extreme weather events, and antimicrobial resistance. So we're doing a lot of work with the community care, through collaboration with OVISA and with community health workers with C# to look at the interface of lived experience and health outcomes, and look at how people's living environment and their socioeconomic standing, which is influenced by many things, including race, gender, ethnicity, has a direct impact on health outcomes and healthcare access, and what we can learn from that with the work that we're doing. We've done a lot of work, and I don't want to go through this too much, but this is the work that we're doing with South Africa and with India, and we've had some really interesting insights by speaking to climate activists, to gender activists, to a much broader range of people than we would normally do research with to understand this from these different perspectives. And then I came across this paper which was published in South Africa, and they had interviewed policy and health experts to try and understand. There were 20 people that they had interviewed to understand within the South African context, from the perspective of expertise, what is the relationship between health and they call it climate change, but I think it's said. And what they identify is that these experts saw it as an opportunity, particularly as national health insurance is being discussed in the context of South Africa, to actually challenge the healthcare system to operate and restructure differently. I don't know how realistic that is in the current climate. But they also suggested that there should be a climate change and health responsibility assessment framework, and they had very interesting considerations of how that could be shaped in South Africa. But one thing they pointed to, which I didn't know, is that this UN Provia Programs of Research and Climate Change Vulnerability Adaptation, which was actually published over 10 years ago, they themselves within that report couldn't agree how a response to climate events in relation to health it should be rolled out, whether it should be top down or bottom up. And then they also discussed how communities have for centuries, for millennia, managed to live and thrive within the environment in which they work, and there is much that we can learn from indigenous knowledge practices, and that is important to bear in mind. Slide on that work we are doing. But then how do we translate this back to policy? So as part of our WHO TDR work, We also are looking at the policy space around climate change, gender equity, and AMR, and there's a lot of siloed work that is happening. We looked specifically at South Africa and India. And for me, having looked at the evidence and the research that we're looking at, is trying to understand who are we generating the data, how can we communicate much better at the policy level, so that the science that is being generated will actually make a difference to health outcomes of people who need it the most. And coming onto the indigenous work, so I'm only seeing a lot of research looking at how current public health campaigns in Southern Africa are using indigenous knowledge practices to be able to be more impactful and widely reach communities. And there's a lot of learning around from that as well for work that we are doing, including around climate. And this is something that is coming through the community work we're doing with FSI in Kailicha, but also with the community health workers, how much everyday living conditions are impacted, not by climate change, but everyday weather, like the floods we had 2 weeks ago, how much it impacts communities and their ability to access healthcare, to be able to go to school, to be able to come to our workshops. Everything was impacted. And this is known. We knew, we planned, anticipating for the flooding. We actually planned to cancel one of our workshops. So we knew what the consequences were. And the community did lose their homes. A lot of them lost their homes. Some of them are living now in the town hall. There was in one of our subsequent workshops, one of the community members identified a member in their vicinity that had died from pneumonia because they lost their home due to the flooding. So we know these things are happening, and what are we doing with it? So coming back to the question at the beginning, is it marriage of convenience or love marriage? I don't think it's either of those things. I actually think it's more of a convergence of a set of circumstances that come together to potentiate and exacerbate how we are experiencing health in countries. This is a very interesting book that was published to learn from the Zika outbreak, and I use my University of Liverpool credentials to download the book so anyone wants it and share it. But there's a whole chapter on convergence, and he uses the example, the author uses the example of Zika virus to talk about how climate events are not going away. They have been a phenomenon forever. As long as humanity is existing, we need to learn how to respond to it in a manner that is actually most beneficial to people who are most vulnerable to the climate events in relation to health. And some of the key stresses that he finds is how we communicate with technical experts. As scientists, it's very compromised that we're not doing it the right way. And identifying in a timely manner to strategize about engaging with policymakers is really important. And that is the kind of work that we are trying to do in relation to antibiotic resistance, and Sam Kelly's doing a lot of work around how do we communicate about AMR to communicate the risk associated as we see it with this pandemic, so that people who are non-experts can also resonate with it and act on it. Because that's one of the things when you look at the literature, there's so much more literature for AMR than there's climate change. I mean, there's much less noise around it outside of the non-expert groups. So I think we have a lot to learn about communication. We're doing a lot of work around that with community health members for World Antimicrobial Awareness Week last year. We had community members come here, but also working through AWOSA with adult community members to try and bring in their narrative and their lived experience into the research so that it is counted for and recognized. So for me, it all goes back to who is vulnerable in any country, in any given setting, and how is that vulnerability made worse by the intersection of climate events and infectious diseases that are happening. But do we really need to learn from Zika or from these pandemics that we have? I think it's something that has always been there, and that is our human response to these crises that is very predictable. So I don't know if anyone's read The Grapes of Wrath, but it's a really powerful book about climate change. Although it doesn't claim to be, it's about in the oppression era in the USA and the severe droughts that led to a lot of farmers. So it's happened. It's something that has happened historically. This is a fictionalized version of it. But the farmers lost their land. The banks came in and repossessed their land. So the farmers became day laborers, and they became migrants in the US, and they were marginalized and victimized for being migrants in their own country. But also they became day laborers so that they had to compete for the cheapest labor. And today in America, that is happening with nurses. So companies in America are putting out nursing posts for the lowest bidder to take. So we are constantly abusing systems that are wonderful to be abused, and we don't learn from this cycle. And the other thing, if you haven't read that book, is there is a very powerful depiction of hunger. Not malnutrition, not undernutrition, or whatever else we call it, just sheer hunger and what that does to the human body, but also what it does to society. And in our work here in South Africa, we're seeing a lot of hunger comes through as a problem in the patient populations that we're seeing in relation to antimicrobial resistance. And then, of course, again, this issue with migrants and how they are treated is still happening. It's happening today here, it's happening in Europe. So I don't know how much modeling we need to do to understand the relationships and the devastating consequences when these conditions come together. So I'm going to finish my talk with this quote from the book The Plague, which says pretty much this, that we know pandemics are going to happen. I added the bit in red is my writing. I think the author missed that. Maybe they should have included that in their novel. But it's about why are we taken by surprise when this is something that has happened over and over again? And we know what we're going to do the next time. We're going to do exactly what we did in the last one. So this one.